Hello, I'm Elliott Singer, one of the medical directors with Londonwide LMCs, and I'd like to speak to you today about the changes to the GMS contract, and in particular the changes made to the clauses relating to access and how, in spite of these, we can still look to provide safe patient care. So the Schedule 3, little 4, states these points on here. And these are the major changes, and I'd like to take a few moments to go through these in a little more detail. So the clause little 1 states a patient who contacts the contractor. So what does this actually mean? Well, someone can contact you either in person, on the phone, via online platforms or other online systems such as the NHS app or text messaging. That is a contact. If somebody has tried to contact you and didn't get through, that should not be considered a contact. So the needs on their access would not apply. These are just covering those points just made. Moving on to little 2 on this, there's a few points to cover here. So the first is it states that it needs to be at a time which is appropriate and reasonable, having regard to all the circumstances. So when we think about circumstances, you need to think about, do you have the capacity? What's the urgency of the problems you're dealing with? And is this urgent? No time frame is associated with this, so it's perfectly acceptable to give the patient a future appointment. It does not necessarily need to be that day. B states provide appropriate advice. So how do we provide this appropriate advice? Well, it could be responded electronically to the patient. And that would include text messaging or email as well. It could also mean signposted them to NHS online resources. All these would be appropriate advice depending on the situation. C states direct the patient towards appropriate services which are available to the patient. This is a really important clause, as this is what gives us the permission to direct patients to other services, which could include your community pharmacist, your optometrist, your dentist, but also includes 111, UTCs and A&E. And this is the first time within the clause that it's clarified that we have a right to refer people onto other services. D contains 2 parts. One is about request further information. And so if a patient contacts the practice and doesn't leave any information, it is perfectly acceptable to be able to advise and triage them appropriately that they are to begin to provide further information for this. And that until we have that information, there is no need to take action on when they need to be seen or how or by whom they need to be seen. The other relevant circumstances point also means that we need to again think about, do we have the capacity, the lack of capacity, or is there urgent emergency problems that the practice is dealing with that means they can't deal with this problem at this moment in time? Again, these are just those points covered in more detail. Little 3 states we need to make the appropriate response. The appropriate response in this situation could be about same-day appointment if received during core hours, but equally, if it's out of hours, it would be the next day. The final clause says not jeopardise the patient's health. This is an unusual clause in the respect of what would we do that would jeopardise the patient's health. We have overriding professional duties, which would be counterintuitive in a contract like this to be anything that would cause them health problems. But equally, if it's in the interest of patient safety, the practice was unable to meet the patient's need, or it was unknown if a delay would jeopardise the patient's health, then again, we should be diverting the patient to another appropriate service. So underlying all of this is that we have a duty to provide safe care. This duty is contained within both the GMC medical practice and the relevant clauses there, but also within your requirements under CQC to provide safe quality of care. And those are the statements listed there. So we do have a duty to do this. But why? Why, apart from the duty, why would you want to? Well, actually, by providing safe care, it means that we've got a manageable workload. If we have a manageable workload, it is less likely that staff are going to leave because of the pressures of work or want to reduce their commitment due to the pressures. So we have better staff retention. In the long term, better staff retention will mean that we do have more appointments for our patients. And as a result of that, can provide high quality care and access. And again, that high quality care and access leads you back to safer care. So we need to be thinking about this. When we consider how do we do it to provide safe, sustainable care, I want to break this down and I want to cover a number of different points. One being thinking about realistic rotas, another is capacity, what is a GP to patient ratio, how do we involve our patients and communicate to them, and lastly, what about training for non-clinical staff? So the BMA has done a lot of work in this area, in both the safe working in general practice and the workload control in general practice documents. The recommendation is that we should be seeing 25 patients per day or consulting with 25 patients per day. This, of course, is for average complexity of patients. And if they're very complex patients, we may find that we can't safely do 25 appointments. The point of this is to give us more time with each patient. We know that the complexity of the cases we're dealing with in general practice is increasing. And as a result of that, it's unrealistic to be thinking that we can do this within a 10-minute appointment. So we need longer appointments to deal with the patient so that we can actually meet their needs. But the other thing is that for clinicians and the sustainability of doing the job for a long time, we need to be able to complete the tasks of the day, including all the clinical administration, within a normal day's work. It should not be the norm, which is often come of late, that people go home to log on to start clearing their path links and their prescriptions and any other tasks. This is not sustainable for the long term. And we need to think about how do we make the job doable so that people can actually have a long career in general practice and we don't see people retiring or leaving the profession earlier than they would otherwise like to. So the capacity. Firstly, is about the appointment system. As I've said, this is about reducing the number of appointments per session, which means you have longer appointments. So my advice on the appointment system would be to actually do these at 15-minute appointments, not have 12, 13, 10-minute appointments so that they're done in sort of 2 hours, but that it's the full 3 hours as per the BMA model contract for salaried GPs that we're utilising to see our 12 patients. Because that way we're sending messages out. We're sending messages out to ourselves that we have time to deal with these people and that we don't need to rush through and we don't feel that pressure. But also from a system point of view, that they can see how we're utilising our time to add higher quality care by giving patients longer time. The question is, how many appointments should we be offering for our populations? Well, actually, there's nothing within the contract that actually states a number. However, there has been work done in the past, and a lot of people would have heard before this figure of 72 appointments per 1,000 patients. This was originally worked by the management consultants McKinsey for NHSE, that they came up with this figure. Unfortunately, how they derived of this, the evidence backing it up, and actually the original paper isn't available. So it's hard to find out how they got to that, but nonetheless, it's a useful figure because it's often used, and it's actually used within the standard London GMS contract, and is also described in the BMA document on safe working in general practice. The next question is, out of these 72 appointments per 1,000, how many should be with GPs? We work in a multidisciplinary team. This is not just about GP appointments, it's overall capacity. There's no absolute figures on this, but in the past, some of the CCGs as were, within their local contracts that looked at capacity, stated figures such as 40% of appointments needed to be with a GP. So when you're looking at your appointments and what you've got available, are you offering 72 appointments per 1,000 as a minimum? If you are, that's good, because then if challenged, you can compare it to actually what's been requested by the system. And then what percentage of those are with GPs? And if at least 40% are, again, that's justifiable based on figures that the system has utilised in the past. And you should know these figures, and you should also publicise them, which we'll come on to in a moment. Another key figure to be aware of is, what is your GP to patient ratio? Now, there was a study done in 2009 that found that patients' perception of care decreased when you were more than 2,000 patients per whole-time equivalent GP. The actual data looked at 20 hours per 1,000 GPs, which roughly equates to the whole-time equivalent of 40-hour week would be 2,000 patients, which is where that figure comes from. And if you look at what's happening in London, and the figures on the screen are as per April 2023, you can see that across London, we're more than that figure. And for most of the areas, we're significantly higher with less GPs per patient than is ideal. Now, this is important to know from a system point of view, because it's a system problem. This is not an individual practice problem. And we need to start thinking in terms of the workforce as a system level problem. But equally, know what it's like within your own practice. And if you're not at this sort of level, could you be? Have you tried to recruit? Is it financially viable? Because if challenged, again, this is a useful figure to have, but also what actions you've taken to try and address it is equally as important. And I would suggest that that you do publicise this sort of data wider as well. Which leads me on to keeping patients informed. And this is probably one of the key things in the whole of this. And there's two main ways I would suggest that you keep patients informed. One is how we use the telephone, and the other thing is our websites. So with regard to the telephone, one of the key components of the plan for recovering access in primary care is cloud telephony. And now, this may have some benefits, it may not, but one of the things I would suggest to you is a benefit is it's easier to change messages. And if you're not already doing this, you need to think about this. Because actually what you don't want is patients holding on the phone for 30 minutes plus just to be told you haven't got any appointments, please call another service. From a complaint point of view, we often get complaints because people do get irritated by hanging on to be told there's nothing, and then they complain there's no appointments, there's never any patient appointments, I can't get hold of a GP. We know the reality that everyone's working to capacity, so let patients know this and think about how you change your telephone message depending on what you have available for the day. This also then fulfills clause that we mentioned earlier, which is 4.2c in the contract about directing people, because there's nothing wrong with saying on your telephone message, we are now at capacity for the day. If your problem is an emergency, please keep on the line, and our receptionists, our care navigators will advise you on how you can receive some help or medical attention. Words to that effect. Think how you can put it on there, but do change those messages to keep people informed. Leading on to the websites, more and more of our patients are accessing our websites. So on there, you should be saying how many appointments you offer per 1,000. Again, we often get challenged that we can never get appointments. So having this figures readily available makes people realise what sort of capacity there is within the practice. It's also useful that if you have some key staffing issues that are affecting capacity, you put an alert on the website about that, again, as a way of keeping patients informed. If we do this, it's less likely to lead to complaints because people know what's happening, they get to understand why, and therefore they're less likely to complain when it doesn't go as their expectations are that it should go. So please think about how you use your telephone systems and your websites throughout all this. Care navigators, next thing to consider. For most of us, our receptionists or care navigators, as their sort of role is developing, we need to think about what we can put in place to help them. Care navigation is not triage, and it's really important to differentiate between clinical triage and care navigation. Care navigation is somebody advising a patient on services that they may access to try and get the help they need. It is not triage of a case. And the reason why this is important to differentiate is, one, they need training on how to do this, and a lot of the training should be provided by your ICB. Again, part of the GP Access Recovery Plan, but also as employers, you need to think about what training do you need to help them on this journey. And I do use the word journey because taking them from a place of a traditional receptionist of just booking in the practice to having an awareness of the other services being available, and when it's appropriate to suggest to a patient that they may want to consider doing those, is a different skill. So we do need to think about the training here. As part of this, our ICB should be producing a directory of service, a DOS, because if they don't, and people aren't aware of the services on offer, sometimes the only option will be to send to 111, urgent treatment centres or A&E, and this may not be ideal. With 111, a lot of the time, patients may find out they're in a bit of a loop, that they're referred back to the GP or onto A&E, or it's not always the most appropriate way. So that's why it's really important that if you haven't got a DOS from your ICB, that you do go to them and you ask them the question of what services should you be referring into when you're at full capacity. So the obvious question is this actually possible to do? Is it realistic? So let me give you a real life example of a practice. So during the pandemic, a practice moved over to on the day only booking. And at the same time decided, on safety grounds, that it was going to limit appointments to 13 per session. This takes it to 26 contacts per day, so almost at that 25 number. On a daily basis, the duty doctor calculates how many appointments they can offer, and this is based on the clinicians available on that day. So it's a day, it's what is the capacity on that day. When the request comes in, they're added to a duty list, and the duty doctor triages those to the most appropriate person, but will also deal with some of the more simple things such as med-3 requests, if it's prescription requests, etc. That gets filled up over the course of the day. Now, depending on the day, depending on their training practice, depending on how many trainees are around and how many clinicians are around, to be what their capacity is. And of course, if those people, lots of those people are away, as sometimes happens, the capacity on that day is going to be a lot less. So at some point, they may get to the point where they're at full capacity, but they take some steps before that. Approximately 25 slots before they've reached full capacity, they turn off their e-consults. And the reason for this is that if you have multiple entry points for patients, it's a lot harder to control the flow. And we don't want suddenly to find a dozen e-consults have appeared when you just don't have the capacity to deal with that. So about 25 cases before full capacity, that's turned off. Then depending on the day, when there's 10 to 15 slots left, the message on the answer phone is changed. And this is changed to say that we have reached full capacity today. If your problem is an emergency, please hold and we will direct you to an appropriate service. But it gives the patient the option then of either holding on or not. What we also find is that, again, depending on the number of appointments you have per day, then you either need 15 or maybe a few more appointments to hold if you're closing the list really early on. But if you're getting to mid-late afternoon, having those 10 appointments or even less can be more than enough. So you have to be flexible in the approach to this. The interesting thing is that the aim was that all the clinicians are able to complete the work within the working day, not take work home, not have to log on when they're home. And it's achieved this as well. So they're spending longer with individual patients and they're getting all the clinical administrative work done within the day, and it feels much more achievable for those that are working this way. There hasn't been an increase in practice complaints about this. One would worry that this would happen because your capacity is less than what it would be previously. And there's not those complaints about been waiting on the phone for such a long time, because the messages are updated and people are keeping updated the whole time, which helps. To do this, you do need to be brave. It is a little bit of a jump in terms of a system change, and involve your PPGs and your patient groups to let them know that this is happening. But it does take a little bit of being brave. But you need to consider what's the alternative. The alternative is that you keep dealing with unmanageable demand. More and more feel that we can't do it anymore and reduce down our work commitment or stop work completely. And that further reduces the capacity in the practice. You then get the domino effect until it becomes unsustainable to keep the practice going. And it's for that reason that we would strongly suggest you look at this and you consider moving over to a system that is about safe practice and safe care for our patients and sustainable workload for all of us and all our colleagues. We do keep the information updated regularly, so please visit the Londonwide website for regular updates on this. I hope you find this useful. Thank you very much.